Thank you very much, Stephen and Michael, for the opportunity to present here today. So I'll take you through the first presentation, which will be on surgery in Ontario and some of the challenges that we confront. So I'm expected to put my disclosures at the start of all my talks. I'm a member of a research group which has a policy of not accepting honorariums or other payments from industry for our own personal financial gain. We do, however, accept honorariums or payments from industry to undertake research endeavors and costs to participate in meetings. And based on study questions I originated in grants I've written, I've received grants from many different companies. They're listed here. And I've also participated in some advisory board meetings and expert panel meetings. So if we look at non-cardiac surgery in Ontario, annually there's about 200,000 adults who undergo major non-cardiac surgery in Ontario hospitals. This is not day surgeries. This is patients who will be admitted to the hospital for their surgery. Approximately half of these patients are aged 50 years or greater. 60% are female. Approximately 2/3 have elective surgery, but that also means that an appreciable proportion undergo either urgent or emergent surgery. The age and the comorbidities of the patients undergoing non-cardiac surgery in Ontario is steadily increasing over the last 20 years. And among patients who are aged 50 years or greater within 30 days of surgery, 10% have a major complication, 6% will be readmitted to the hospital, and 1.5% of these patients will die. Importantly, only 0.6% of the patients who are going to die will die in the operating room. 99.4% of the deaths occur after surgery. And what is remarkable about this point is that surgery should or could arguably be the highest risk period, because that's when, in fact, people are being intervened upon and they're under anesthetic care. However, what we see is, in fact, if anything, it's actually the safest period, and that becomes very important about thinking how we may make advances in postoperative care in the same way that there's been very dramatic improvement in intraoperative care throughout the last century. Importantly, of the deaths that will occur, 30% of the deaths are occurring after hospital discharge, and once again, this highlights where there's potential for us to improve outcomes for patients. If we look at the complications that happen after surgery that are independently associated with death, 5 stand out. They include myocardial injury after non-cardiac surgery, which we call MINS. They include major bleeding, sepsis, new atrial fibrillation, and stroke. The way this table is set up is that the second column shows you the incidence of each one of these major complications. The third, the adjusted hazard ratio, and the fourth, the attributable fraction. And the attributable fraction basically tells you what proportion of the deaths in the first 30 days after surgery are likely caused by this complication. And as you can see, the 3 dominant things that lead to death in the first 30 days after surgery include myocardial injury after non-cardiac surgery, major bleeding, and sepsis. Now, challenges in the area that exist in Ontario include 5 things that I'll address. The first is a suboptimal approach to preoperative risk estimation. The second is suboptimal monitoring. The third is the fragmented nature of care. The fourth is suboptimal follow-up, and the fifth is funding. When we think about perioperative or preoperative risk estimation, it is important to offer accurate preoperative risk estimation because, number one, it allows patients to make informed decisions about the appropriateness of surgery, and it is a necessity of informed consent. It also allows physicians and surgeons to identify patients who require enhanced postoperative follow-up. It can also guide management in terms of what type of anesthetic approach may be used or whether or not an open versus a laparoscopic approach will be undertaken, and it can facilitate shared care models. 40% of patients undergoing non-cardiac surgery in Ontario are immobile, and as a result of this, the clinical history ends up being insufficient to estimate risk because these patients are very immobile who are undergoing orthopedic surgery or vascular surgery or surgery for a cancer. When you ask them if they get chest pain or shortness of breath, the patient may tell you no, but the problem is that they may still have very significant cardiovascular disease, but because they're so immobile, they don't end up getting symptoms. As a result of this, there has been a lot of focus on how can we improve risk estimation. And in Ontario, 9% of adults who are undergoing non-cardiac surgery will end up having a non-invasive cardiac test. This is despite the fact that I will show you in a moment, they have limited predictive capabilities and they cost substantial amounts of money. The VISION study was a prospective international cohort study that a large group of us undertook internationally. We included patients who were age 45 or greater undergoing inpatient non-cardiac surgery. It was a representative sample of patients having both elective and urgent or emergent surgery, day, night surgery, or surgery during the week or on the weekend. We had 23 centers in 13 countries from all of the inhabited continents of the planet. This slide shows you the relationship we established between patients, their postoperative high-sensitive troponin T thresholds, and 30-day mortality. And we systematically measured these assays in all patients having surgery. And what it shows you is that if your peak troponin after surgery is less than 5, that appears to be normal, and your risk of death at 30 days is 1%. If your value is 5 to 14, it independently increases your likelihood of dying over threefold. Your risk of death is 0.5%. If it's 14 to 20, it independently increases your likelihood of dying at 30 days ninefold with an adjusted hazard ratio of 9. However, your risk of death is 1%. And if you're 20 to 65, your risk of death jumps to 3%, and the adjusted hazard ratio is 23. Now, a priori before doing the study that we established that, in fact, we were looking for adjusted hazard ratios of 3 or greater and an absolute risk of death of 3 or greater. So a threshold of 20 is what actually we use based on this research to identify people having important heart injuries, myocardial injuries after surgery. We also identified another threshold of 65 to less than 1,000. Here, the absolute risk of death jumps to 9% at 30 days, and the adjusted hazard ratio is 70. And finally, if your high-sensitive trope T value is 1,000 or greater for surgery, your risk of death jumps to 30%, and the adjusted hazard ratio is 227. This raises the question of should we be monitoring perioperative troponins? And in the VISION study, 93% of patients who had myocardial injury after non-cardiac surgery had it without ischemic symptoms, and this likely would have gone unrecognized without troponin monitoring. And these elevated postoperative high-sensitive troponin measures without ischemic features, ischemic symptoms, increase the risk of 30-day mortality with an adjusted hazard ratio of 3.20. In other words, patients not having symptoms after surgery but still having heart injury, these events are not benign. They're substantially increased in the likelihood the patient will die. And the problem is most of these events happen in the first 2 days after surgery when patients are receiving analgesic medication that can mask typical ischemic symptoms. We also demonstrated in the POISE trial, we had 415 patients who had an MI, and 2/3 of these patients did not have symptoms with their heart attack. The risk-adjusted association with death at 30 days for symptomatic and asymptomatic MI was almost the same, with over a 4-fold increase. So based on this, we should be measuring troponins perioperatively. I'm now going to present a case that also highlights the problem with perioperative monitoring. This is an 83-year-old female who was participating in a perioperative troponin study. The patient had a history of hypertension and a 20-pack-year history of smoking, but had stopped smoking 30 years previously. The patient had no known history of coronary artery disease, peripheral vascular disease, stroke, and had a normal ejection fraction prior to surgery. This patient underwent a large surgery on February 7th with a lower anterior resection, loop ileostomy, and a vaginal wall resection for a rectovaginal fistula. The surgery went from 1825 to 2200 in the evening. Intraoperatively, the systolic blood pressure was 80 for 10 minutes and 90 for 20 minutes, and these are relatively unremarkable intraoperative blood pressures. Postoperatively, the patient was getting an epidural, and their IV was running at 125 cc's an hour. When the patient arrived on the surgical floor, their heart rate was 91 and their BP was 110 on 55. The next time their vitals were checked or recorded to be checked was 5 hours later. And at that time, the heart rate was 84 and the BP was 78 on 40. We don't know when the blood pressure dropped, but I'll show you information in a little bit that suggests it dropped substantially before it was detected. At that time, the surgery resident was called. They ordered the 500 cc bolus of normal saline. The next time the blood pressure was once again recorded to be checked was 6:30 in the morning. The blood pressure now is 70 on 38. The surgery resident is called. They're in the OR, and they said, we'll be up as soon as we're done in the OR. and they ordered an ECG and a CVC. At 8 in the morning, the blood pressure now is 75 on 36, hemoglobin 94, and the surgery resident orders a unit of blood and the ECG. This shows you this patient's preoperative ECG, and for the most part, it's relatively unremarkable and no significant evidence of cardiac ischemia or prior myocardial infarction. When the patient arrived on the surgical floor that night, just after midnight, this was their ECG. It was done, put on the chart, and no one was paying attention to it. But this ECG shows dramatic changes, showing ST depressions across the anterolateral leads and a QS pattern in the anterior distribution, showing that this patient was already having significant cardiac ischemia shortly after midnight, but once again, because of likely the epidural, was not experiencing symptoms, and no one knew about this. At 10:30, the patient's systolic blood pressure is 60. A code is called. We end up coming to see the patient. We admit the patient to CCU. We give them inotropes and fluid. The blood pressure normalizes, and the high-sensitive troponin assays are elevated. The next day, the patient gets some chest pain. We take them to the cath lab. They have a critical narrowing in their left anterior descending artery, and the patient is getting a stent and does okay. However, this whole event ideally would have been prevented or detected much sooner. And for certain, there's some patients like this who don't have a good outcome like this, and we don't even get to discover this. The high vision study was another study that we undertook, where we, just in under 600 patients who went to the surgical floor, we put on continuous oxygen monitoring versus standard nursing care, where the nurses just measured vitals as they normally do. The nurses said that 5% of the patients became hypoxic on the surgical floor, and then we looked at the 95% of patients who the nurses said weren't hypoxic. 38% of those patients had at least one continuous episode where their oxygen saturation was less than 90% that lasted for at least 1 hour in duration, and 10% of the patients had at least one episode where their saturation was less than 85%, lasting for at least 1 hour in duration. And hypoxemia, SATs less than 90%, for more than 5 minutes in duration, have been associated with increased risk of myocardial ischemia in the perioperative setting. This just highlights once again how suboptimal monitoring leads to a lot of missed events, and in some patients, substantial delays in identifying things are going wrong. And so finally, I just want to state that we also have other limitations in our system beyond simply the issue of how we're doing risk assessment and how we're monitoring our patients. The fragmented nature of care in perioperative medicine has also led to challenges. We need to move to shared care models where both surgeons and experts in medical care are involved in the care. We also, at the moment, have suboptimal follow-up. Most patients are discharged from hospital and seen maybe 4 or 6 weeks later by a surgeon. And once again, the result is that 6 to 7% of those patients will be readmitted to a hospital in a 30-day period. We need transition to care measures which can actually minimize this risk, where we can interact with patients who are high risk, frequently see their wounds, and also monitor their vitals. Another problem that exists is the funding mechanisms. So as an example, I mentioned earlier that in Ontario, 9% of people are getting non-invasive cardiac tests before their surgery. These tests cost typically $500 to $1,000, and they're not very predictive. I will show you in a moment in the next talk that we can use simple biomarkers that cost 20 times less and are substantially more predictive. The challenge is that our hospitals get money for us doing non-invasive tests, whereas it's a cost to our hospitals to measure the biomarker. So even though the overall system will be way better off measuring the biomarkers, the system is incentivized to do the more expensive testing. We need to change that setup in order to have a better overall system for our society. So in conclusion, surgery is common. It's occurring in older patients with more comorbidities. Myocardial injury after non-cardiac surgery, bleeding, and sepsis are the major causes of 30-day mortality. Challenges that exist in Ontario in the current surgical setting is suboptimal approaches to preoperative risk estimation, suboptimal monitoring in our patients once they leave the recovery room, the fragmented nature of perioperative care, suboptimal follow-up, and the funding mechanisms. And in the next talk, I will address some of these points. Okay, my next talk. So, steps towards worry-free surgery in Ontario, top 10 insights. So, unfortunately, my disclosures have not changed since my last talk. They remain the same. A number of things that I'm going to talk to you about in this presentation come from the Canadian Cardiovascular Society's guidelines on perioperative risk assessment and management for patients undergoing non-cardiac surgery. This was published just last year in the Canadian Journal of Cardiology. So just as a bit of background, because I'll talk about a number of points from these guidelines. These guidelines were developed where first, all the questions that were relevant were identified. We then undertook literature searches. We used grade quality assessments, and there was discussion and voting. All academic and intellectual or financial conflicts of interest had to be declared. Conflicted members could participate in discussion, but were not allowed to vote. The voting required for a recommendation a two-thirds majority of non-conflicted primary panel members. Two-thirds felt the evidence was too weak for recommendation and no recommendation could be given. Or we could also do a good clinical practice statement if two-thirds of the majority believed a recommendation was indicated based only on values and preferences. All conflicts of interest in voting were documented in the appendix to the paper. Okay, well, what I'll tell you is what this slide talks about is the use of a biomarker before surgery to predict death and heart attacks. And this marker is NT-proBNP or BNP. It's a simple blood test that we can measure with point-of-care testing in pre-op clinics. And what it just shows you is how dramatically NT-proBNP predicts who will die and have a heart attack. So if your value is less than 300 or less than 92, your risk is 5%. However, if your value is 300 or greater than 92 for BNP, your risk jumps to 22%. And compared to the revised cardiac risk index, which is the standard clinical model to predict risk, if you use NT-proBNP before surgery, you will more appropriately put 155 patients out of 1,000 in a better risk category. Yeah, okay, unfortunately these aren't projecting, but so based on this, step one, or top one recommendation is that we should be measuring NT-proBNP or BNP before non-cardiac surgery to enhance perioperative cardiac risk estimation in patients who are age 65 years of age or greater, or 45 to 65 years of age with significant cardiovascular disease, or who have a revised cardiac risk score of 1 or greater. This is a strong recommendation based on moderate quality evidence. Next is the issue of coronary CT angiography. So this is one of the non-invasive cardiac tests that probably cost, in true cost, at about $1,000 before surgery. So the main data from this comes from the coronary CT angiography vision study, which in just over 950 patients, these patients had preoperative coronary CT angiography, which is a way to non-invasively look at coronary arteries. And the results were blinded unless there was left main disease. And the preoperative coronary CT angiography demonstrated that the findings of extensive coronary disease did enhance risk prediction in the perioperative setting beyond clinical information. However, coronary CT angiography data overestimated risk amongst the patients who did not suffer primary outcomes, in contrast to the data for NT-proBNP. And if you, in fact, do coronary CT angiography in 1,000 patients pre-op, compared to just clinical information, you'll put 81 patients in the wrong category of risk, highlighting why this is not a good strategy. So based upon this, the recommendation, or the top second recommendation, is against performing preoperative coronary CT angiography to enhance perioperative cardiac risk estimation. This is a strong recommendation based on moderate quality evidence, once again, because we have a much cheaper modality of dealing with this. The next recommendation here is once again against performing preoperative echocardiography, exercise stress testing, pharmacological stress echocardiography, or preoperative radionuclide imaging to enhance perioperative cardiac risk estimation. Once again, this is happening in 9% of adults in Ontario undergoing surgery. These tests typically cost between $500 and $1,000. And once again, we can do simple point-of-care testing for a biomarker at a 20th of the cost and much more accurate risk estimation. The next point is on smoking cessation. So the data that informed the recommendations around this comes from meta-analysis looking at smoking cessation randomized controlled trials. Smoking cessation at the time of surgery in 12 trials, just under 1,900 patients. A brief intervention where you counsel the patient to stop smoking, enhanced abstinence at the time of surgery. An intensive intervention, you counsel the person to stop smoking but give nicotine replacement, a 10-fold increase in the likelihood of abstinence at the time of surgery. And importantly, 12 months after surgery, the intensive interventions where you counsel the patient but also give nicotine replacement had about a 3-fold increase in the likelihood patients will be abstinent from smoking 1 year after surgery. Right now, data shows that very few patients are given nicotine replacement or smoking counseling prior to surgery. So the recommendation number 4 is to discuss and facilitate smoking cessation before non-cardiac surgery. This is a strong recommendation based on low-quality evidence. This next slide, which I apologize once again doesn't project well, is showing you the data regarding the use of aspirin in patients undergoing non-cardiac surgery. And this comes from the POISE-2 trial, which included over 10,000 patients who were randomized to get aspirin on the time of surgery or placebo. And what it demonstrated was there was no benefit in terms of saving lives or preventing heart attacks, but aspirin substantially increased the risk of very serious major bleeding. And based on this, step number 5, or the recommendation, is against the initiation of aspirin for prevention of perioperative cardiac events. This is a strong recommendation based on high-quality evidence, and against the continuation of aspirin in patients coming to surgery or on it to prevent perioperative cardiac events, except in patients who have a recent coronary artery stent and patients undergoing carotid endarterectomy. This is once again a strong recommendation based on high-quality evidence. Regarding the issue of beta blocker initiation, the data to inform this comes from a systematic review in 2014 of randomized controlled trials. There's overwhelming evidence that beta blockers given around the time of surgery decrease the risk of heart attacks. However, they increase the risk of death and they increase the risk of stroke. And the POISE trial was the largest trial in all these data. However, the results are consistent with or without the POISE trial. So step 6 and recommendation 6 is against initiating beta blockers within just before surgery. This is once again a strong recommendation, high quality evidence. Step 7 is to obtain daily troponin measurements for 48 to 72 hours after non-cardiac surgery in patients with a baseline risk of 5% or greater for cardiac death or MI. This is a strong recommendation based on moderate quality evidence and based upon data that I showed you earlier. This does not happen in probably a majority of centers in Ontario, but more and more centers are starting to do it because the evidence is so strong. I'm now going to switch to present to you some recent data from a trial that we just presented at the American College of Cardiology late-breaking trial session, and it will be published in the Lancet in the coming weeks. And this is the MANAGE trial. And background is myocardial injury to non-cardiac surgery includes myocardial infarction and isolated ischemic troponin elevations that occur within the first 30 days after surgery. It does not include non-ischemic myocardial injury due to things like sepsis, rapid atrial fibrillation, pulmonary embolism, or chronically elevated troponin. It affects about 8 million adults worldwide annually and is independently associated with an increased risk of cardiovascular events and death over the first 2 years after surgery. There's no published trial has evaluated the treatment for MINS. So in the MANAGE trial, we randomized patients to an anticoagulant, dabigatran, or placebo, and using a partial factorial to patients who were not on the proton pump inhibitor, we randomized them to omeprazole or placebo. This was an investigator-initiated trial. We had 84 centers in 19 countries participate. We included patients who were age 45 or greater who had undergone non-cardiac surgery and were within 35 days of having MINS. MINS could be diagnosed based on the universal definition of myocardial infarction or an isolated ischemic troponin elevation. We excluded patients who are at high risk of bleeding or required an anticoagulant or who had suboptimal kidney function. The intervention was that on the day of randomization, patients started taking dabigatran 110 milligrams BID or matching placebo. Once again, this is a low dose of one of the direct oral anticoagulants. And patients in the partial factorials took omeprazole 20 milligrams a day or matching placebo. Patients took the study drugs and were followed for a maximum of 2 years or until the trial terminated on November 30th, 2017. The primary outcome was a major vascular complication, which was a composite of vascular mortality, non-fatal heart attack, non-hemorrhagic stroke, peripheral arterial thrombosis, amputation, and symptomatic venous thromboembolism. The primary safety endpoint was a composite of life-threatening major and critical organ bleeding. We randomized 1,754 patients to dabigatran or placebo and 556 patients to omeprazole or placebo. We followed patients for a mean of 16 months, and the follow-up was complete on 99% of participants. The baseline characteristics was that patients on average were 70 years of age. It was 52% of patients were male. 20% of the patients get into trial because they met the universal definition of myocardial infarction, but 80%, the majority, had an isolated ischemic troponin elevation. The time from MINS to randomization was a median of 5 days, and importantly, 91% of these patients didn't have any ischemic symptoms with their MINS event, and without systematic troponin measurements would have been missed. The primary FC endpoint of a major vascular complication occurred in 97 patients in the Bigatran group, 11%, and in 133 patients in the placebo group, 15%. In other words, dabigatran decreased the risk of major vascular complications by 28%, and this was a highly statistically significant result. This shows you the Kaplan-Meier plot for this result, and what you see is the curves immediately divided. They continue to divide till 1 year, and importantly, these events are still occurring after 2 years of follow-up. They continue to rise. The primary safety endpoint of life-threatening major critical organ bleeding, there was no difference between the dabigatran group or placebo group. So the takeaway message from the manage is that patients with MINS are at high risk. 1 in 7 patients suffered a major vascular complication at 16 months of follow-up. 91% of the MINS events were only detected through troponin screening, and clinicians would not recognize most events without routine perioperative troponin measurements. And among patients with MINS, dabigatran 110 milligrams BID decreased the risk of major vascular complications with no observed increased risk of major bleeding. So step 8 recommendation is to prescribe dabigatran 110 milligrams BID to patients who have MINS. Step 9 recommendation is to evaluate and implement continuous non-invasive monitoring on patients after surgery and into the home setting, and a lot of research is now going into this area. And we need to create a new discipline of perioperative care where specialists in perioperative care are available all the time for patients, because the current model where surgeons are busy in ORs and not able to respond to patients creates a problem. And step number 10, recommendation number 10, is to resolve the funding silos that exist in perioperative care. As I mentioned before, right now in Ontario, we're spending a lot of money on non-invasive cardiac tests that are not that predictive, but from a hospital point of view are more efficient compared to measuring a simple blood test, which is 20 times less expensive and substantially more predictive. So in conclusion, 10 practical steps to improve perioperative outcomes in Ontario include the following. Starting to use the biomarker NT-proBNP or BNP before surgery to predict risk, to stop using preoperative coronary CT angiography or other non-invasive cardiac tests before surgery, to discuss and facilitate smoking cessation before surgery and into the postoperative setting, to not initiate or continue aspirin to prevent cardiac events except in patients having carotid endarterectomy or who have a prior coronary artery stent, to not start beta blockers before surgery, to obtain daily troponin measurements for 2 to 3 days after surgery in at-risk patients, to prescribe dabigatran 110 milligrams BID to patients who get MINS, and to evaluate and implement continuous non-invasive monitoring of patients after surgery and into the home setting, and to create a new discipline of perioperative care, and to resolve the funding silos in perioperative care. Thank you very much. I'd be happy to take any questions.
Thanks very much, PJ. That was a very interesting top 10 insights, as well as an overview of surgery in Ontario. I think that what I'll ask people to do is if there's any questions, they can use the chat box to share their comments or questions, and then we can address those. But before we do that, maybe I'll just pass it over to Mike to give some insights from our work here at the forum on the related topic, and sort of just discuss what you brought up in your presentation.
Great, thanks, Steve. And thanks, PJ. Some very compelling findings, and I think just things that have a lot of impact on surgery in Ontario and elsewhere. So, what I want to talk about is just to give a sense of some initiatives that we've done at the forum in partnership with PJ. So in the fall, we convened a citizen panel followed by a stakeholder dialogue on the topic of taking a step towards achieving worry-free surgery. So the citizen panel brought together 11 citizens who were diverse in terms of lived experiences, where they lived in the province, and other variables like socioeconomic status and ethnocultural background. And then following that, we summarized the results from that panel and included them in an evidence brief that went to a group of 19 stakeholders, which included a policymaker, 5 managers, 9 healthcare professionals, a researcher, and 3 stakeholders. And for both of those sets of deliberations, the focus was on identifying views and perspectives about the issue. So what's driving the issue around, I guess, in essence, suboptimal perioperative care, and then turning to solutions. So what are the ways in which that we can address or take a step towards achieving worry-free surgery in Ontario? And there are a number of things put on the table to deliberate about, and then implementation considerations. And with the stakeholders, we then asked them also, what are the key next steps that they think could be taken? So I just want to give a very brief overview of what was said about the key challenges by citizens and by stakeholders, and then also what the next steps were that were identified. I think many of which flow nicely from what PJ has said. And just to reiterate that PJ was very critical in helping to pull together both the panel and the stakeholder dialogue. So this is as much my work as it is his as well. So to start with, worry-free surgery was a concept that we are using in the Department of Health Evidence and Impact as one of our areas of focus to try and champion change in this area, and which is part of the reason why we wanted to convene the panel and the dialogue to try and kickstart some action in the province to make some impact. We define it as engaging the patient and the care team in the decision-making process about whether to proceed with surgery in light of the patient's needs, conditions, values, and preferences, minimizing risks for perioperative complications by proactively identifying and addressing risk factors, and then using care pathways that are informed by the best available clinical practice guidelines. So much of what PJ just talked about. So in light of that, there were some reactions to the term, but there were a number of people around the table who said that, who saw worry-free surgery really as a call to action, or in other words, as a horizon objective or an aspirational goal that could really be used to create some buy-in among health system leaders and stakeholders to try and achieve evidence-informed perioperative risk assessment and management in the province. So there's clearly many gaps, and the idea is that this could be a call to action to close those gaps. So the participants really emphasized the need for perioperative risk assessment and management be informed by the best available research evidence and not just the clinical practice guidelines. So, for example, some of the new findings that PJ just shared with us now. So in terms of the issue, that when people were thinking about this in terms of their experiences, what they see as constituting worry-free surgery, in particular, many of the citizens said that worries evolve throughout their surgical journey. So, and that some worries may come and go at any given time. Many people, and they also said that many different people worry about surgery-related complications. It's not just the patient and caregivers. It could be citizens in their capacity as taxpayers or health professionals, managers, and policymakers. So there's many that are involved, and we need to focus on those as well. And then one of the most important areas of worry was the lack of information and communication throughout the surgical journey, which is seen as often the greatest source of worry because it exacerbates a sentiment of uncertainty about the surgical procedure and associated risks. So it's a big intervention and a big source of worry, and so lacking information and communication about that makes it worse from the patient's perspective. At least that's what we heard in the panel. And so a number of people identified important aspects that could be, or important ways of achieving worry-free surgery. So the citizens in particular said that what will be important or essential is information sharing and clear communication between the patients and the care team. So information about their health condition, the benefits and risks associated with each treatment option, and what to expect before, during, and after surgery. Information sharing across the system, so having a comprehensive system in place to systematically collect and share patient information across providers and settings, ensuring continuity of care throughout the surgical journey, co-creating a care team, so where patients and caregivers are a part of that care team, and co-creation of support systems needed by patients and caregivers, as well as personalization, so patients and caregivers having different personalities, skills, competencies, and worries, and those need to be considered. In addition to those, the stakeholders who came to the dialogue So these are the policymakers, managers, professionals, researchers, and so on. In addition to those, and agreeing with those facets of the problem, identified the limited availability and contextualization of perioperative data in the province as a key issue that needs to be addressed. So they saw this as a key challenge because many pointed out that in recent years, most of the data-related efforts in Canada have been focused on collecting and reporting data on wait times for priority procedures, so things like cataract surgeries, hip and knee replacements, hip fracture repairs, and so on. But the view was that similar investments haven't been made in perioperative data, and the result is that that data ends up being lacking when we need it, and it doesn't address the right issues, so the potential causes of, and not just the rates of readmission and 30-day mortality. And then several also emphasized that patient voices are often not included in data, despite many calls across the system for greater use of patient-reported outcomes. As a note, though, some were optimistic about progress being made in the area by the Ontario Surgical Quality Improvement Network and the National Surgical Quality Improvement Program, which tracks a number of indicators that allow surgeons and hospitals to compare themselves with their peers, but it's only limited to a small set of hospitals within the province. So with those challenges in mind, when we came to the deliberation about the next steps, folks around the dialogue table identified a number of next steps, many of them very focused and that could be taken on, but will need buy-in from policymakers and others in the system to make it happen. So I'll just go through them, and then we can leave it there and open it up for any sort of discussion. So the first is that it was seen that there's a need to spread awareness among health system leaders of the importance of streamlining perioperative risk assessment and management, and in particular, really emphasizing on ensuring that standards of care are consistent across the province while being sensitive to the province's most vulnerable population. So you heard PJ talk about a number of things that, standards of care that aren't being taken up, or aspects of the guidelines that aren't routinely done. So that was a big part of that action item. So the second was supporting existing communities of practice to try and build quality improvement capacity among health system stakeholders, and to provide those communities with the tools that they need to streamline and optimize the perioperative risk assessment and management. So again, trying to support the quality improvement agenda across the province and not just in particular hospitals. And supporting the development of training opportunities for professionals to support optimal perioperative risk assessment and management. So an example floated was developing training opportunities based on the competence by design approach promoted by the Royal College of Physicians and Surgeons of Canada to foster a culture towards evidence-informed and value-based practices. The fourth was to ensure that the work is always done with partners across the health system to establish a consensus on what perioperative data should be collected. So, and to make such data more easily available. So that plays on the main challenge. One of the main challenges that was identified in the stakeholder dialogue about the need to have more integrated and accessible data in this area. And then to explore the types of small-scale innovation projects that could be designed to optimize perioperative care and to build the case for the uptake of the MINTA guidelines. And I think PJ gave a number of examples of those innovations that could be routinely adopted. And then the dialogue finished with identifying aspects of a research agenda that could be used to strengthen perioperative risk assessment and management. So this included things like empirically examining how the lack of timely access to surgical care can affect worry-free surgery, pilot testing new and emerging technologies to support remote monitoring. So given that we live in a province with such a vast geographic landscape, how do we connect people from remote areas to better follow them? Developing and assessing patient risk calculators to try and better and routinely assess risk, assessing the effectiveness of interventions to engage patients and caregivers in risk assessment, but also examining the cost effectiveness of new financial incentives to improve perioperative risk assessment and management, so things like bundled care. And you heard PJ, I think, talk about this in his talk around the fact that we have very cheap ways of identifying risk through biomarkers, but the incentives in the system aren't aligned to support their uptake, even though it will benefit the system significantly, just not within the hospital. And then examining the most cost-effective way to support the uptake of clinical practice guidelines. So I'll leave it there. Those are the main action items that came out of the dialogue. I'll All of the products that came out of the panel and the dialogue are available on the forum's website related to taking a step towards achieving worry-free surgery. We can provide those links somewhere, I'm sure. And they're all open access for you to access.
Great. Well, thanks very much, Mike, for that reflection. I'm going to open it up here into the chat. If anybody has any questions for either Mike or PJ, please use the chat box to ask those. We'll just wait a minute and see what if any questions come up, but I would just like to, in the meantime anyways, thank PJ and Mike for joining us today. It was very, very interesting presentation and discussion. So,
thanks, Steve.
I
can start off with a quick question while we wait if you want. It's for PJ. So, PJ, you talked about a lot of different things which I find really interesting. I guess just in your experience, what do you see as the main barriers in really taking up some of these clinical changes? You talked about a lot of very impactful findings, but it seems like there's a big challenge in getting folks to take them up across that system level.
Yeah, well, maybe what I'll do is I'll use an analogy that might inform the answer to the question. So initially when surgery started, there was an anesthesiologist. And then anesthesiologist came along, and the focus of the anesthesiologist was, number one, to provide anesthetic care so that the patient would, not have pain and not experience what was happening. But importantly, they were then responsible to, make the patient safe from a physiological point of view, to allow the surgeon to focus on what they were doing, which was the surgery. And that allowed for dramatic improvements in overall mortality that happened in the ORs, because someone was focused and paying attention on the patient's physiology while the surgeon was doing surgery. And I think one of the big problems we have right now in perioperative medicine is that we, in general, have very good outcomes in the OR, but the problem is when people leave the operating room, we have suboptimal monitoring, but we also have a system where overwhelmingly it's the surgeons who are responsible for the care. And the problem is surgeons are busy in ORs most of the day, and patients don't wait to get sick. And then even when patients go home, once again, they're probably going to be seen 4 to 6 weeks later by the surgeon. And some of those patients are going to get significantly sick before that happens. And I think, what we need to do is learn from the model that was so successful in making the biggest advance in surgery, which was the introduction of anesthetists to help, manage patients during the OR, and create a new type of perioperative care model after surgery, where there be shared care with surgeons, but by physicians who were available all the time, whose only focus was to medically manage the patients after surgery and to help manage patients into the home setting who are high risk, with being able to frequently interact with them through tablets and various means to see how they're doing, look at their wounds, get their hemodynamics, and see if they're stable. So I think that one of the largest barriers at the moment is that we've not organized ourselves in an optimal way after people leave the OR, and that has led to a lot of the challenges that exist. That's one of the things that we're trying to tackle in Hamilton, but that has been, I think, one of the bigger challenges at a global level for implementing a lot of the things that make obvious sense to improve outcomes in this setting.
Thanks, PJ. You mentioned it briefly there, I believe, but I'm just curious about the use of telehealth as a tool for that follow-up care. Is that something that you find a lot of people are using already, or do you think that's something that would be helpful, or is that it comes back to the same question of people not having enough time to manage the follow-up care because they're busy doing surgeries and other things anyways?
Yeah, so for certain at the moment, it's not being used hardly at all. We're doing research on this right now. We're doing a randomized controlled trial where we sort of have much more continuous non-invasive monitoring of patients even on the surgical floor with early alert systems compared to just normal care. But then when patients are going home, if they're in the interventional arm, they are given a tablet which we can then interact with them daily. We can then take a picture of their wound and look at it. We also give them some technology that can measure their vital signs for us several times a day at home. And the goal is that we can then hopefully pick up if the patient's getting early signs of infection or the patient's getting into some heart failure or anything early, with the hope that we can then manage that before it becomes a big problem and requires hospital admission or results in a really bad outcome like death. So I think at the moment it's not being used. I think that there's enormous potential in this. In fact, I am absolutely convinced that the next big frontier that is going to fundamentally change and dramatically improve the safety of surgery is to do what we did, as I said, in the OR, with bringing someone the domain of anesthesia to focus on simply the patient and their management, and to create that same kind of domain into the post-operative setting with enhanced monitoring into the home setting, of which telehealth will be an important part for those higher risk patients. Because as I said, in Ontario, if you think about it right now, 6 to 7% of people are being readmitted to a hospital. That is a lot of money. If we could cut that in half, which I believe we absolutely can, by doing, a system where, in fact, we're more frequently monitoring those patients, I think they could do a lot of good for our patients in Ontario.
And do you think that monitoring, PJ, needs to be done by a physician, or can some of it perhaps be done by others, such as a nurse practitioner? I know it probably depends on the severity and the complexity, but
so for certain, I think that the overall care model should not simply be physician-based. The way that our research is organized is that it is nurses who are doing the first interaction on a daily basis with the patient, but based on certain parameters, then that is escalated up to the doctor in certain findings, looking at the wound or the hemodynamics, et cetera. So I think that it doesn't have to be a model where it is the most expensive, provider being a physician, but for certain, having other healthcare providers involved with this can make it both efficient and practical and cost effective.
All right. That's great. Thanks so much. I don't see any other questions coming in, so maybe what we'll just do is see if Mike or PJ, if you have any last comments, and then we'll wrap up the webinar for today. Mike, do you want to start us off?
Sure. So in what PJ was just talking about with the discharge kind of made me think of that it's highly relevant for surgery, but I also think it's highly relevant for other areas. So getting this right in surgery could have very important spillover effects into other areas. And the one in particular I was thinking of is that we just ran a dialogue about how do we improve transitions from the cancer care system to home and community care, given that I think the findings, it's a staggering number of people have indicated in the Canadians that their needs are not being met during the transition period. So I think a similar model could have big impacts in cancer as well as in other areas, and just as you said, avoiding that hospital readmission was not necessarily keeping in a safe and improving mortality rates and so on.
Yeah, I completely agree, Mike, that I think there is lots of areas of medicine that could benefit from better monitoring and transition of care into the home setting. There's no doubt about that. And I think, part of what happens in medicine, we all get busy and we get focused on doing our things, and most of us, pay most attention to sort of acute, dramatic problems. But we have to recognize the shifting that happens in medicine. So as an example, there's an endless push to have people discharge home sooner. But we need to make sure that there's models of care which can facilitate safe transitions and ensure that, in fact, patients don't get into trouble and require costly readmissions at subsequent dates because of suboptimal transition. So I think a lot of what we're discussing and exploring in the surgical setting, you're right, has application to lots of other settings, from cancer to just older, sicker patients on medical floors.
Great. Thanks. We actually just had one question come in, PJ, that said thanks for the insightful discussion. And what do you think it will take for funding to shift from the traditional, more expensive, and less predictive tests you had mentioned towards the more cost-effective biomarkers?
Yeah, so it's a complicated issue, and I'm not an economics policy expert by any stretch, but the current model where hospitals are rewarded for doing outpatient imaging tests, but they're not rewarded for doing something cheaper that's a blood test within the hospital, that silo has to be broken down. And I think the first fundamental way to go about doing that is making policy experts aware of that problem. As I said, it's in the economist no-brainer corner. We're spending a lot of money for less effective tests, but it's because it's incentivized in the wrong way. And having first policymakers understand that, and then with policymakers thinking of more inventive ways where, in other words, hospitals won't be compensated or penalized in some way if they're using inappropriate tests, but at the same time the cost would be covered for the much cheaper, much more predictive tests. And so I think it's going to have to come back to working with policymakers, but the first step is to make them aware of the problem and to help, and then to work with them to figure out what are practical solutions that can overcome inefficiencies in our system.
Great. Thanks, PJ. Well, I'd just like to say thanks again to PJ and Mike for joining us today. We really appreciate you taking the time to join us for